Good afternoon. The House Appropriations Subcommittee on Human Services will now come to order. Clerk, will you take the, well, now we can go. Clerk, will you please take the roll?
Chair Roth,
Here.
Vice Chair Kelly,
Here.
Representative Mueller, Representative Beeson,
Here.
Representative DeSanta, Vice Chair Edwards,
Here.
Representative Longjohn.
Here.
Mr. Chair, you have a quorum.
Thank you, Madam Clerk. Thank you very much. And we're going to have Representative Beeson moves to approve the minutes of June 24th, 2025. With no objection, the minutes are accepted. I did it twice today. All right, we're going to have some conversation today. First up, Nick Griswold, CEO from GrowthWorks. We're going to bring Nick up. We're going over today just some of the things that we are dealing with in our budget, in our department. GrowthWorks does a lot of work around their wraparound services for juvenile justice in the Wayne County area. And when you're ready, guys, go ahead. Thank you for being here today.
Thank you so much. Chairman Roth, committee members, we really appreciate you guys having us here today to talk about our Rescue Recovery Program. My name is Jordan Selleck. I'm the Executive Director for the Conference of Western Wayne. We are an organization that represents the 18 communities in Western Wayne County. We serve over 730,000 residents, and the 18 mayors and supervisors from those communities sit on our board of directors. We've been around since 1979. And throughout the past 40 years, we have partnered with GrowthWorks on various initiatives to serve our communities. So Rescue Recovery began because our first responders were really struggling with constant overdose calls. They would respond to an overdose only to get called back to that same person a couple hours later, either because that person initially refused treatment or they were taken to the emergency department and then released with minimal to no options for help. So we partnered with GrowthWorks, the state of Michigan, and St. Mary Mercy Livonia, which is now Trinity Health Livonia, and 4 of our communities to start a pilot program that offered peer recovery coaching services. These peer recovery coaches would respond to people in active addiction distress. From that, we were able to expand to all 18 CWW communities and offer 24/7, 365 coaching response to clients in need. So at this time, I'd like to have Nick, who's, as you said, CEO of GrowthWorks, talk more specifically about the Rescue Recovery Program itself.
Thank you, Chairman Roth and members of the committee. It's good to see you again. I was here a few months ago talking about our work in the youth justice space, and so it's great to be back and talk about something that's just a little different, but also just as vitally important, I think, to our area and to the clients that we serve. I did bring data because that's what I do. You're going to learn that the more and more I come here. And so if I can move the slides. There we go. Jordan talked about that. I talked a little bit about GrowthWorks, but just so you know, we've been around since 1971. We started as a youth drop-in center in downtown Plymouth, Michigan. We've expanded significantly since then. We now serve Western Wayne County entirely and really Southeast Michigan more broadly with a lot of our services and programs around youth and families. So I want to talk about what a peer recovery coach does because I think that's important level setting and what we feel that at GrowthWorks, what peer recovery coaches do. So they really do 3 things. They help clients build a foundation of recovery by sharing those lived experiences and introducing them to new ways of living, thinking, and participating. We also help clients gain recovery capital by connecting them to treatment resources, community support, and ongoing recovery work. There's a lot of research. A lot of the top research in the country suggests that the more and more that folks that are suffering from substance use disorder go or are connected to either treatment services, recovery activities, community supports. If they can do that, the research says for 22 months, they have a 90% likelihood of long-term recovery. It's really great statistics, but it takes that everyday work to get those 22 months under their belt. And really, and we've been talking about this a lot in our office lately, is increasing hope. Just trying to give, whether that's kids, adults, families, hope again, motivation, and then provide support and accountability to encourage those changes in their lives. And I'll talk a little bit about what coaches, more about what coaches are, but I kind of want to talk about what Jordan just mentioned, which is this cycle of addiction in public safety, which is really what brought us to this work in 2017. So I'm going to start at the top of the wheel here. So a person uses substances. This is what we saw in our communities. Person uses substances, and then they require an emergent medical response. So EMS, fire, public safety is responding. They're providing those immediate life-saving measures. That could be Narcan. That could be, they might be having a co-occurring physical health condition. So it could be having a heart attack or something like that related to substance use. So the EMS responds, and then they transport them to a local hospital for that continued diagnosis and treatment. No fault to anyone, but those patients can sit in the ER for a little while, depending on how busy the ER. As you might imagine, this sort of thing doesn't usually happen during the middle of the day. It can happen all different times of the day, but we've seen in our research and our work that it's really overnight hours is where this really gets busy. And they might wait a while. Then eventually they're going to consult with a healthcare personnel, doctor, nurses, and then they're going to be provided resources. That immediate life-saving care, of course. So if they're in there for a heart attack, obviously that's going to be dealt with. But a lot of times, hospitals aren't the place for that long-term ongoing treatment that's necessary for a positive outcome for substance use disorder. And so they're going to be given resources, maybe connected to treatment. What we saw is a lot of times, as Jordan alluded to, clients by that time have kind of come around. Maybe the effects of their substances have worn off, and they'll often leave the hospital against medical advice, and then public safety will encounter them again. And I remember being in a room with police chiefs and fire chiefs back in 2017 and just talking about the hopelessness that our public safety first responders felt, because they knew that they were going to drop that client off at the hospital and that they were probably going to see him again in a couple weeks and save their life again, and then have to see them in a couple weeks. And it's hard when we see our first responder heroes feel so hopeless about something like that. So how do we get involved? Well, really what we do is we intersect at that moment where they're at the hospital. So we send a peer recovery coach into the hospital. I could talk about that. Just to back up a little bit, the hospital is given an 800 number that they can call a dispatch center and receive a coach. We have about 20 staff that work in this program, just so you know. So it's small but mighty. And when those calls come in, dispatch center is going to dispatch a peer recovery coach. We respond to those calls 24/7, 365. And we dispatch a coach in less than 45 minutes. And that's really important because, like we talked about, while they're in the hospital, the effects of substances are wearing off. They're receiving, it's a traumatic situation for them, for everyone involved. There's a little window of time. Our coaches call it the moment of clarity. There's this little window of time where someone can hear that message about having something different for their life. But it's hard for that to come from a doctor, a nurse, frankly, even a clinician. We employ treatment clinicians, LMSWs, counselors, psychiatrists, psychologists. But where that message really gets through is for someone who has been in that exact same position. I know what you're feeling. I know what you're going through. I know what your family's thinking, because that's what my family thought of me too. And here's how we do this together. And then they immediately connect them to treatment. I'll drive you there. Let's go now. Let's, remove all the barriers to treatment, even helping them navigate public mental health systems so that they can get into treatment as quickly as possible. When we do that, we have a 90% likelihood that that person is going to accept that offer for help and go to treatment. And we think that's really successful. And we think the difference is because it happens during that window of clarity. That also allows us to break that cycle, that public safety cycle that we originally talked about. GrowthWorks peer recovery coaches will continue to engage the patient for up to 1 year after initial contact. And I think it's important to note that the treatment that we're talking about, most of the time that's not with an agency like GrowthWorks. They might need partial hospitalization. They may need long-term residential treatment. They may go out of state for that treatment, depending on their circumstances. And no matter what the outcome of that is, our coaches are going to stay there and be connected to that person. So if they go to a treatment program in a residential facility for 90 days, let's say, then when they come out, that coach is right there ready to say, what are the next steps now, right? Because we know that recovery is a lifelong journey. And I'm sure that each of you, if you stop and think for a moment about a family member, a friend of a family member, or a friend that you have that's experienced this, I think unfortunately we've all been touched by addiction in our lives, that recovery is not a straight line. And that's the hardest thing. Honestly, I get in rooms like these and to convince folks of that who haven't had that experience. If you know, you know, but if you don't, then it's hard to grasp that recovery is not a straight line. And so having that coach that's continuously there to be able to check in, to be able to connect to those recovery supports. Remember, we're trying to get to 22 months of recovery-based activity for a 90% likelihood of long-term results. And so a 90-day substance use program is not it's just the beginning. It's certainly not the entirety. And then what I would say is that you might imagine it takes very significant resources to operate a 24-hour emergent program like we operate. And there isn't anywhere in the system currently, and we could have that broader discussion, I suppose. There isn't anywhere currently in the system that pays for this work. You have to register clients after the fact. Sometimes it can take a few hours to get them registered through our partners in the mental health systems. And by then, like I talked about, those clients have already AMA'd, they're already on to their next thing. And so I think that it's really important, the work that we do, and we've been so appreciative of the legislature over the last few years to support the work that really saves lives. To date, I wanted to show you some results real quick too. I told you I brought data. So to just give you an idea, this is where the coaches come from, right? So we're responding to two area hospitals right now, Trinity Health Livonia Hospital and Trinity Health Ann Arbor Hospital. And then we also get some district court and community referrals. But that's 873 contacts from October of 2024 to August of 2025, with 90% of those accepting help and getting into treatment. If you go back all the way to it would be the 2018 fiscal year for the state, the first year that this program was funded, we have contacted and helped over 6,000 people who have been transported to area hospitals, shown up at police departments, district courts, get into treatment. And I didn't bring slides to show you, but I sent to the clerk, and we can provide even more information. Because this was a pilot project, a cooperation between the legislature and the Conference of Western Wayne and Trinity Health, we put pretty extensive reporting requirements on ourselves in terms of showing the efficacy of this work and being accountable for the dollars that we were given to do this work. And so I sent you the last 2 years annual reports that we file with DHHS so that you could see. There's all kinds of data in there. I didn't want to go over all that now, but it's in there so that you can see. And that report generation goes back to 2018. So all those reports are available if you want to see sort of the total picture of what we've been able to accomplish, really with not only our work, but more importantly, I think it's the cooperation and the partnership between the Conference of Western Wayne, all those elected leaders, all those police chiefs and fire chiefs, and an organization like GrowthWorks, and the hospital systems, of course. We talked for almost 2 years to get the partnership right before we went out and sought the resources to actually put the work in place, and I think the results speak for themselves. So I want to thank you so much for the time, Chairman, and if you have any questions, of course, we'd be happy to take them.
Great, appreciate it, Nick. 20 staff for about 873 clients, right?
They're busy.
Yeah.
Yeah.
Per time, though, at any given time, how many patients potentially or clients would they be with?
Yeah,
You know?
if you do the math, that's somewhere between 2 and 3 calls for service per day, every day.
Right.
You might know this, especially if you've had experience with this, in, like I said, in your family or friends, but the holidays can be hard times for folks in substance use, so our calls go up in November, December, January. A lot of people find recovery right around the holidays too, so it's a great time to be engaged. There's some seasonality to the work that we do. Like I talked about before, a lot of the work is done in the evening or overnight hours, so our coaches are on call, a lot like like nurses and other healthcare staff in hospitals might be on call and then get called in, and our coaches are there, ready to take those calls and respond if necessary. And then we have a small group, about 5 or 6 of those 20 are full-time people that come to the office every day, and they're doing all the legwork during the day, right? So they're helping doing all the back-end data collection, all that kind of stuff, connecting to treatment, and other things that just kind of have to happen during the business day with other organizations.
That's great. Now, because we split up the DHH budget kind of 3 ways, do you pull from every budget, or how does the funding get to you?
That's a great question. I think this is in Chairman Van Workum's budget technically, but I think that the work, and certainly the work that GrowthWorks does, kind of expands, spans all areas
right.
of the DHHS budget.
That's what, I mean, we obviously handle juvenile justice here in this committee, and so you're dealing with, if you had to guess, how many clients are part of the juvenile justice system?
With this program,
Yeah.
not too many.
Not too many in this program.
Yeah, this is mostly adults that are being transported for
yeah.
this kind of crisis.
But you do-
we do substance use disorder treatment for adolescents, and we have a fair number of folks that are in that. This is usually when folks are experiencing very significant substance use disorder. And so I can't say it can't happen at 14, 15, 16. Very occasionally we'll see that, but usually that's a 18 to 25 and
Okay.
up sort of thing where we're dealing with it here. Or like I said, those co-occurring. So we'll have folks that come to us that have been heavy substance users for 10, 15, 20 years, and it's starting to take a toll on their physical health. And so then they're engaging with EMS and hospital systems.
Any questions? Go ahead, Representative Kelly.
Just how much money is RD receiving for your services?
Last year's legislative appropriation was $1 million.
Representative Beeson.
Thank you for being here. And what you guys are doing is a very, it's a hard getting people to work. My wife did that for a lot of years, outpatient, and it's a Friday night call at 12:30 at night, and then Sunday night is another night. My question is which legislator put this pilot program in place back in, who got?
It was
18.
Laura Cox was the original person who did it in 2018.
That's all I want to know. Thank you.
Representative Longjohn. You have a question? Yep.
Thank you, Chair. Sorry, push the button. I'm out of practice. First may actually be a question to our clerks or to yourself. There are some reports referenced, the last couple annual reports. Are those coming our way?
Yep,
Okay,
sent to you
great.
right now.
Thank you very much. I actually want to build on Chair Ross' question about kind of the revenue question. I've spent decades kind of in community health work, so you don't have to sell me on the peer support model. I know the outcomes, I know the cost savings, right? But on the revenue side of this, I'm curious if you can share, you had $1 million from a pilot. If you could talk about kind of what your pie chart of revenue kind of looks like at all, just thinking about the sustainability of the model.
Sure.
I'm curious as to what is coming into the model as one-time funding versus whether some of the new G codes that turned on for peer support this year have been incorporated into Medicaid and getting you whole or more sustainable. If you could talk to that for a
Sure,
minute.
absolutely. Yeah, so I don't have the pie chart with me. I would say we're probably about 75% the legislative appropriation, then about 25% from behavioral health sources. DWIN is our mental health provider in Wayne County. We're a provider with them. And so that's about the split. In terms of your other question, I think that certainly the ongoing coaching, peer support work that we do, we try to, whenever possible, have that funded through public health sources, and that does help with a lot of the ongoing stuff. The challenge that we're experiencing, I don't know that there's a change for this other than having opportunities like we've had with the legislature helping, is to really get around the idea that clients have to be registered in those services before they can be seen or helped. And it just, and I think that the Wayne County system does a fine job, but I think that Wayne County is a big county and it's a big machine down there to get people through. And so in our experience, it can take hours to a couple days to get someone registered for services, and it's just far too long.
And as you mentioned, a relatively high proportion of your clientele are sometimes hard to reach, right? So
That's a nice way to
cutting,
put it, yes.
for example, cutting the opportunity for reimbursement under claims, cutting that retroactive window from like 90 days to 60 or 30 makes it harder to get that kind of revenue back in on the back end if you are able to get that kind of revenue.
Yeah, it could. I mean, we're working in the 24 to 48 hour range as opposed to that's just the model that we're talking about here. But I think that funding for this kind of work, I just share with you, I was on one of my board committees met this morning, and so I was on Zoom down in the lobby, and we were just talking about there just isn't the kind of resources that there needs to be for particularly substance use disorder treatment. And that's been the case for as long as we've been around, and I've only been with GrowthWorks 8 years, and it was pretty clear to me on day one that there's not a lot of money to pay for this work, which I find, I have reasons why, and we can talk offline about why. But
Thank you. And if I could, Chair, the final question to either you, Mr. Griswold, or I'm sorry, I wrote down Jordan, but I didn't write down your last name. Ms. Selleck. There's proposals to change the way the PIHP system is working in Community Mental Health Agency. I heard you say you were a subcontractor to some of that, and I know Western Wayne is not the full county, so, could you forecast at all how some of the changes that are being proposed by the department could impact what you're talking about?
no, it's hard to understand, to be honest. So as a very small provider in a very big system in Wayne County, we're trying to understand, like I think a lot of organizations are, just how these changes will really affect us. I would say that Wayne County is already a very big system, so if we're going to reduce the number of PIHPs around the state and go to bigger systems, I would have thoughts about that overall. But to be honest, I'm not exactly sure how it's gonna affect us.
Thank you. Thank you, Chair.
Vice Chair Kelly.
Thank you, Mr. Chair. So let me just these touch points. So you pick them up. They're in the hospital, and you get the call, and then you send out a coach, and then you register somebody there,
Yeah. So
and then do you get reimbursed for a registration?
So eventually, we will get reimbursed for all the ongoing care once that client is approved in the system. But it doesn't start, on the substance use side in Wayne County, it doesn't start at the moment of contact for us.
You find them in the hospital.
Yeah.
You send a coach.
Yep.
He or she gets them to go to treatment, takes them to treatment.
Yeah.
Are they still not registered for, at what point are they in the system?
By the time they're into a treatment facility, they will be in the system.
Then you get reimbursed?
For anything we do after that moment.
Once they're registered?
That's correct.
So you could pick them up, you could go to the hospital, convince them to go to treatment, take them to treatment, and there do they possibly not get registered at the treatment?
They would by then.
Oh, they would?
They would, yeah. Treatment centers, like especially if we're talking about residential or inpatient treatment centers, they're not going to take a patient until they're registered.
Okay.
In the system, and I think but they have a little bit of time once that person is there.
All right.
To kind of let that process.
Out of
play
these 873 people, how many times have they been registered?
I don't have data for that. That'd be an interesting question.
I would think it'd be high number. If cops are seeing these people repeatedly, the treatment centers are seeing them repeatedly.
It's possible. Yeah, I couldn't say how many.
Okay, thanks.
Thank you, guys. Thank you for being here. And no other questions? Appreciate it.
Thank you,
Thanks,
Chairman.
Nick.
Thank you.
Yep. Next up, we're going to have Mona Mackey. Mackey. All right. And Jessica Kowalski. Welcome, ladies. And they are with Access Community. And we appreciate you coming forth and providing some testimony. Go ahead when you're ready, ladies. When we get you all set up to go.
Good afternoon, Chair Roth, Vice Chairs Kelly and Edwards, and distinguished members of the committee. Thank you for your time and your commitment to learning more about the process of obtaining substance use disorder services within the community mental health system in Michigan. We deeply appreciate your interest in this important issue that affects so many Michiganders. My name is Mona Mackey. I'm the director of the Access Community Health and Research Center. Access is the Arab Community Center for Economic and Social Services. It is also the largest Arab American community nonprofit in the nation. We provide over 120 different services. We reach about anywhere from 80 to 100,000 unique clients every year, offering over 1 million encounters in the Tri-County area. We are proud to say that we are contracted by the state of Michigan and the Detroit Wayne Integrated Health Network to provide both mental health and substance use disorder services. Joining me today is my colleague Jessica Kowalski, who serves as the Deputy Director of our Medical Services at Access. Together, we bring experienced perspectives to help illustrate the reality of navigating the current system of care. Investing in substance use disorder services is not only the right thing to do morally, as we all know, but it is also the smart thing to do economically. Strong treatment systems lead to fewer arrests and less strain on the criminal justice system, as we just heard, reduced homelessness and emergency service utilization, and healthier, more productive communities overall. While Michigan has recently seen a decline in opioid overdose deaths, substance use disorder remains a serious public health concern that requires sustained attention and resources. We must continue to invest in the treatment now to prevent further escalation and avoid greater costs down the road. That being said, efficiencies within the system could be significantly improved, and that is what we are here to speak about today. I would like to walk you through the process of an individual who's accessing community mental health services must go through in our state. Currently, the journey begins with a phone call to the PIHP. In our case, that's DWIN. The intake call lasts at least an hour and a half, excluding any hold times or language barriers, during which an individual is asked a lengthy set of questions. At the conclusion of the call, the PIHP determines which agency will receive the case and schedules the first appointment. Sometimes that could take up to 2 weeks. At the first agency appointment, the focus is primarily on paperwork. The client must sign consent forms to allow DWIN to release their chart. This process alone takes close to an hour, sometimes longer. Once submitted, DWIN then has up to 24 to 48 hours to release the file back to the agency. Only on the second appointment can the ASAM, which is the American Society for Addiction Medicine assessment, to be completed. A detailed evaluation to determine the appropriate level of care. The assessment can take up to 2 hours. Then, at the third or even fourth appointment, the therapist is able to complete an individualized treatment plan and beginning the necessary referrals, whether that be peer support, psychiatric care, transportation, employment, and other vital support services. In short, a client who courageously reaches out for help with substance use disorder must go through as many as 5 separate appointments before they can meaningfully begin treatment. From staff reports, 4 out of 5 clients do not make it through the process to get the treatment portion of their care. Fortunately, there is a process on the horizon, effective October 1st, thanks to the state, assuming responsibility for the CCBHC program from the PIHPs. The process will be slightly simplified. We will now be able to conduct the CCBHC intake process directly for anyone seeking outpatient substance use services. This change streamlines care, removes the middle layer of authorizations, and ultimately gets people into treatment faster. However, there is still substantial paperwork requirements for the CCBHC model that the SUD clients have to complete, including but not limited to 6 consent forms, orientation checklists, a level of care assessment, an integrated biopsychosocial assessment, the ASAM assessment, the pre-plan, and the treatment plan. This is all needed before someone can even begin treatment. So before I hand it over to my colleague, I gave a folder up front, but this is all the paperwork that it's needed to complete. And, when we take a moment to think that these folks that finally have the courage to seek help and make that call, that this is the process that they all have to go through. This is where we lose people. This is why people are not able to access treatment in the state of Michigan for community mental health. I mean, it's just overwhelming. And I remember, talking to someone, and she told me, do you know how long it took me to make this call? And I felt interrogated, and she was in tears. Luckily, she called me, where I was able to kind of, talk through it with her and kind of explain the process and help her to, again, believe in the system. So I'm going to hand it over to my colleague, Jessica, to kind of talk a little bit more about the challenges from here.
Thank you all for hearing us today. And I know the paper probably looks a little overwhelming to even those sitting before us, and so we appreciate your time and your commitment to this process. I want to talk about some of the remaining challenges that we still see aside from the ones that Mona has already discussed. So because of these processes, many individuals are seeking substance use disorder care, are forced to look outside of the community mental health system that's supposed to be providing it. In my role as the Deputy Director of Medical Services at Access, we often see patients turning to our primary care clinic instead. In the primary care clinic, we can initiate treatment as a walk-in service without paperwork burden, without authorization, without interrogation, and usually that first step for those suffering from certain substance use disorders can be medication-assisted treatment. Those are the things like Suboxone and Vivitrol and all the other medications you hear about. But what we found is we can initiate that and get to that later. Typically when somebody is in a better space to kind of deal with the paperwork burden that we know is coming their way. We can do this the very same day they're ready to get help, right? They ask for help, they get the treatment. And that's done in the primary care clinic, which is outside of the community health system in Michigan. So this approach has helped us ensure that we do not lose individuals due to delays or unnecessary barriers, but instead engage them in treatment at the critical moment when they are most motivated to start their recovery journey. However, even with the improved processes that are coming effective 10/1 with the CCBHC model, several fundamental challenges still remain. First is workforce shortages. The state's current requirements for substance use professionals are extremely rigorous. They require almost 2,000 hours of postgraduate, that's after your master's degree, of counseling experience, 186 hours of additional education requirements after your master's degree, and 100 hours of direct supervision by a fully licensed professional if you can find one. While well-intentioned, these requirements severely limit the number of qualified providers. Compounding this, Michigan does not accept transfers of addiction credentials from other states, creating unnecessary barriers to expanding our workforce. The paperwork burden, it just remains overwhelming, and I'll just leave it at that. You guys have seen it, it's overwhelming. It not only discourages the clients from wanting to seek care, it disincentivizes providers from wanting to work in community mental health when they could go work in private practice and not have any of this paperwork requirement. And then lastly, the data misrepresentation that is a result of this. Because the process for entering substance use disorder treatment is so lengthy and cumbersome, fewer individuals pursue it. And as a result, the state level data suggests that there's a low number of SUD seeking care. And instead what's happening is people are avoiding this process and instead presenting with a mental health condition to avoid the substance use process, even though they have a substance use disorder. And so ultimately the data is misleading, and it's not because substance use disorder is less prevalent, but because the barriers are simply higher. So the best approach to successful care is meeting people exactly where they are. And you heard that a little bit from a wonderful partner in the community of GrowthWorks. In the moment that they're ready. So when someone reaches out for help for a substance use disorder, we can't afford to put them through weeks of delays and layers of bureaucracy. We must also address the stigma that continues to surround substance use disorder. This, coupled with workforce shortages, leaves too many people without access to life-saving services. So to move forward, we recommend a couple options for change. Expanding the workforce pipeline by reducing excessive state requirements for credentialing, allow licensure reciprocity so that addiction specialists and behavioral health professionals from other states can practice in Michigan, providing financial incentives such as loan repayment, scholarships, retention bonuses, and paid trainings to encourage professionals to specialize in substance use disorder care, increasing access to walk-in services, developing and expanding more low-barrier treatment options such as same-day access to medication-assisted treatment, telehealth, and simplified intake processes, strengthen prevention strategies to address risk factors early, particularly among youth, expanding risk reduction models that meet people where they are and reducing immediate harm while building trust and engagement, and investing in wraparound models of care that integrate the mental health, the physical health, housing, peer recovery, and social supports that really try to drive home that sustained recovery to get people back into active members of society, right? The healthcare system is only one piece of the puzzle. The rest is getting employment, getting legal support, getting them housing, getting them back integrated into the workforce and the overall economy. And I'm going to hand it back to Mona to talk a little bit about the wraparound model and also some client experience.
I actually had Jessica yesterday reach out to some of our staff, and I said, can you get me a couple quotes just now, fresh quotes of what it was like for some of these clients regarding accessing care. One client said, it felt like the system was designed for me to quit. Another said, it would be easier to overdose and die than to seek treatment for my issues. Another, you have to spend 5 to 6 hours on the phone to get to the right person. These individuals that we serve are our neighbors, our friends, and our loved ones. Substance use disorder, as we all know, does not discriminate. It impacts every community, every family, and every background. When someone is brave enough to raise their hand for help, our system must be ready to respond quickly, compassionately, and effectively. As members of the Appropriation Committee, you understand better than anyone where we invest our dollars reflects our priorities and shapes our future. An efficient, accessible substance use disorder system is an investment that pays off across multiple sectors, reducing criminal justice costs, alleviating the burden of emergency rooms and homeless shelters, and strengthening Michigan's workforce and families. Every dollar spent wisely on treatment today serves so many in downstream costs tomorrow, and most importantly, saves lives. I'm proud to say that Access just broke ground on a 51,000 square foot access to recovery center that's going to provide withdrawal management, crisis stabilization, and short-term residential. We heard about the wraparound model. It's the only way. We have to treat the whole person. If we want to make a movement, create a movement, and help people be, members of society and integrate meaningfully, we have to invest in those people. And Access, hopefully in 2026, fall of 2026, the center will be opening. Thank you again for your time, for your leadership, and for your continued dedication to strengthening Michigan's behavioral health system. We look forward to answering any questions that you have.
Thank you, ladies. I really appreciate the testimony, and wow, nice paperwork, right? Any justification for the paperwork that they can give you? I mean, that's anything.
If you want to tackle, I mean,
Yeah, I mean, a lot of it was for, like I said, it was well-intentioned. It was for accountability, for quality of care control, essentially, to ensure that people are getting the proper level of care. And there was a financial aspect to it, was that if you can determine the appropriate level of care for somebody and spend the least amount of dollars, that would be ideal, right?
Sure.
Well-intentioned, just hasn't become reality. It's just become a mess of paperwork.
and more paperwork.
And
they
more
just keep
paperwork,
adding
yeah.
And more paperwork, yeah. We got paperwork.
Yeah.
Representative Long John.
Thank you, Chair. Just building on that, right? Like, there's some processes here in the paperwork is just about HIPAA compliance, right? Like
Correct.
making sure that you're getting records at the right time from the right people and protecting privacy. How much, in addition to the other reasons you've named, I mean, it's also the case that we're trying to avoid waste, fraud, and abuse by having some of those things. So where is the balance? Where do you see places we can give and find value in having less paperwork while still protecting patient privacy and making sure quality and cost reduction and fraud, waste, and abuse avoidance is the goal? Where do you see the greatest opportunities?
I think removing the inefficiencies that have kind of increased over the years, right? Over time, it's been added. And like you said, HIPAA, protecting and preventing waste, fraud, and abuse are essential components of any healthcare delivery system, whether it's community mental health or primary care, which is my area of specialty. I think remaining with gold standards and not reinventing wheels is a good place to start. For example, you are probably familiar with the ASAM assessment. Very solid assessment, very inclusive, very needed for this population. But when we add another one that the PIHP has created that also replicates and duplicates the same questions that have already been asked, it just becomes wasteful. And I think that's what's happened is over time, it's been added instead of remaining at what's required versus what's desired.
I started with Access about 20 years ago, and my background, I have a master's in clinical psychology. And when I started, people were able to just walk through the doors, and there was just a brief assessment, a referral process. You collected the information. Data is important, risk, liability, like all of that. But it can be done in a way where it's just not redundant, and like you're going between the PIHP and this and that. Like, it's a horrible experience for everybody that's involved, and it's just not efficient, and we're losing people. That's not our goal. Our goal is to get people the help that they need, but yet we've created a system where we say, oh my God, there's treatment and recovery is possible, but wait a minute, you can't access care to even start the process. This is very difficult because we got to understand a lot of these people, as we heard earlier, it's a critical time in their life where they're ready for treatment. That's huge. When we get people to say, yeah, I want help, we got to be ready. Mm-hmm. But when this is the process, it's not going to work. Over and over again. We've seen it time and time again.
So thank you. And I hear you saying that there's some streamlining that you're seeing in the changes that are coming to the PIHP system on October 1. Same question as to our other folks who gave testimony today. How does that whole switch look for you? I hear you saying there's some good things. Is it all good? Mostly good? Where are you?
It just
where do you
removed
feel
that
pain
one
points?
layer, right? But again, the paperwork stays the same. We don't know. To be honest with you, nobody knows what this is going to look like and how it's going to impact the people that we serve and how it's going to impact the providers. No, it's very hard for even us. We're trying to talk to people and understand because we have to prepare. We are responsible for the people that we serve. But I wish I had a better answer. I don't know if you...
Yeah, so to be clear too, that's just strictly the change that we're seeing on 10.1 is only for the CCBHC model. Now, the change that you mentioned before with the PIHP RFP that's going around, I think similar to GrowthWorks, we're all kind of waiting to find out what that looks like. I think we're all curiously intrigued to see, if I can say it that way, to see what happens. But I think we don't have any answers.
Thank you.
And we can't predict it, yeah.
Thank you, Chair.
Ladies, thank you very much. Really appreciate your testimony today. Thank you. Give time for Mr. Hunter, Michael Hunter from Team Wellness Center. Please come up, sir. And you can, Mr. Hunter, when you're ready to go, let her rip.
Good afternoon, everyone. Mr. Chairman and all members of the committee, thank you so much for indulging me today on behalf of the Team Wellness Center in Greater Wayne County, Michigan, and all of the vulnerable adults and children that we serve throughout the state of Michigan. I've been with Team Wellness Center, June made 20 years. And I have seen a lot of evolution in our state and in our approach to human services and community health. And I will say that impressively for me, I've also had the chance to work in Ohio and in North Carolina. And Michigan is a very generous state when it comes to community health. One of the barriers that we have is just access to that generosity. And as you heard from some very dear people to me, that barrier is a lot of times administrative. And when you get that to that point, that's when you run into hurdles, right? But trying to help the people that we serve, you get organizations like Teen Wellness Center, who is probably one of the largest community mental health operations in the state of Michigan. And we are a fully integrated service delivery where we have primary care, dental, behavioral health, co-occurring substance abuse, housing, employment, and all the other social determinants as well. The cool thing about this state, again, is we don't look at each other, other partner organizations, as the competition. We look at ourselves as colleagues because there's so many people to help, and the no-show rate is so high. We're still at 50% or better across the state. And when you think about follow-up, is also down as well. You probably have a 65% if they, as you heard earlier, get through the intake bureaucracy processes. But once you have that person and once you have their undivided attention, if you will, then we get a chance to do what we are designed to do, what the people that have committed themselves to this line of work have designed to do, where they are ready to commit themselves to the success of the people that are sitting across them from the table. Even if that person is indigent, even if that person is covered in bed bugs, even if that person hasn't had a shower in a long period of time, even if that person just does not present well, we are committed to their success. And that's what begins to really set us apart as a state. When we know that somebody can come in our doors at any given moment from any different perspective and we're ready to serve them, now we are on the same page. And what Teen Wellness Center does is we ask ourselves, how can we help? What can we do to help more? Where can we find another avenue that hasn't been covered enough yet, or where there's still a gap in service delivery here or there? So that's why you will find at any of our clinics an opportunity to serve children as well as adults, where you will see that we were eager to step in when the governor and the Wayne County executive needed help with the juvenile detention facility and all the pains that were happening there. And we developed a juvenile restorative program. So we have an opportunity to help children at another level, whether it's criminality, whether it's behavioral health or substance use disorder or a combination of them. We want to step in and help. Where we have redesigned our approach to helping juveniles altogether and opened a family and adult juvenile facility in the city of Detroit, where it looks very, very welcoming. It is fully staffed with a pediatrician. We're working on sedation dentistry and everything that you can need, even in partnering with MDHHS and the foster care system, and having to provide sensitive care, even when there's been allegations of sexual assault. Then we have the kits and the gentle care to take care of those patients that come in, and all of this under the guise of community health and trying to do everything we can to help those people who really can't help themselves. And if a person has a mental illness, a severe and persistent mental illness, getting them to come through that door in the first place is very, very difficult. Most times they're coming to us now through our crisis stabilization unit if it's severe enough, because they have either been arrested or they're acting out in their diagnosis in the community and somebody calls the police and then the police come. And we've worked very closely with the Wayne County Sheriff Department as well as the Detroit Police and surrounding city police to partner with them for their CIT training. And then we leverage our relationships again. So we find somebody, for example, who is, let's say, chronically in the Dearborn area, and especially if they're of Arab descent, we're gonna call Mona's team and say, hey, can you help with this? And can we help with that? And we partner. We pull together the resources that we have, whether it's the mobile unit for crisis and dental or whatever it is, whether it's events. But we really put a lot of effort into making sure that the monies that have been appropriated for community health, specifically mental health and substance use disorders, we are getting some return on that investment. Can we streamline it? Yes. Oh, yes, we really can. But when you're serving 7,000 out of 10,000 people that are on your roster every day, it's a lot. And you know you have a committed team of psychiatrists, clinical therapists, nurses, case managers, all the way down to even our janitors that are helping out every day. And we need to make sure that we can continue to do that and streamline that. And everything doesn't happen, very cleanly all the time. It's not like storybook here. We've had our troubles in the past. We've had fortunate our opportunity to be the location where we had the mass shooting 3 years ago. We have people, of course, trying to commit suicide, and we intervene. But this is a very difficult population to serve. And then when you try to respond to that, for example, with the mass shooting, prior to the mass shooting, which was just not a thing that you saw in community mental health, we had 7 security personnel, and now we have 57 as a knee-jerk response because the staff, now that we put them in place, won't be comfortable if they're not there. So you're trying to juggle all of that and keep people engaged and in this side of the workforce, because you have the competing PIHP saying, hey, we're going to pay you 30% more than the provider is paying you. And we're like, what? You're taking all of our staff and you're leaving us vulnerable. Yeah, we know, but and so you deal with that kind of stuff too. And these are people that we partner with, that we love dearly, that we work hand in hand with all the time. So we still put on our happy face and we still, do the grind and try to make sure that we, at the end of the day, we've helped as many people as we possibly could. And because of your time and listening to entities like us, we have that opportunity and we really appreciate it. And it gives us a chance to be advocates as well. One of the things I do besides being president of Teen Wellness Center is I host a television talk show called My Healthy Mind in Lansing. I think it's on CBS, Sundays at noon or something like that. My Healthy Mind is M-I Healthy Mind. But we talk to people who have been through it, people who have, you just think about how detrimental life can be sometimes, but they've survived and now they want to tell their story to help other people. And that's what we want to do, complement that so that other people can get the same help and afforded opportunity as them. Thank you.
Thank you. Appreciate it. Lot there to uncover or go through. Obviously, mental health is a big issue up in our area too. Recently we had the Walmart stabbing, unfortunately, and that gentleman slipped through the cracks big time between substance abuse and mental health problems. No community's immune to it. So
Correct.
Appreciate your efforts. Any questions, folks? Oh, nope. Okay. Really appreciate your time. Thank you coming
Okay.
to us, sir.
Thank you, guys.
Just keep up good work, and we understand there are challenges that need to be worked on. So
Yes.
thank you for your testimony today, Mr. Honor. Appreciate it. All right. Seeing we're going to have Representative Kelly excuse the absent members. No objections. The motion prevails. Unanimous consent. Appreciate that. And no further business before the committee. The committee is adjourned.